What we're going to talk about is a balance evaluation, particularly how do we medically treat these patients that we do histories and physical and work up for balance dysfunction. I'm going to, as an overview, talk to you about the definitions of dizziness and vertigo, the difference between the two, how we do our patient evaluations using the history, physical examination. Some of the functional exams that we do can be done in the office. Some of them are subspecialized. Radiography has become pretty much routine and available everywhere, whether it's a CT scan or an MRI. A little further down, we'll talk about the differential diagnosis about non-rotational unsteadiness versus true vertigo, and then some of our treatment options that we go ahead and do. From our standpoint, dizziness is any disturbed orientation in space, a sensation of unsteadiness. This is way more frequent than true vertigo. And these are the people that feel like they're on a boat, they're moving back and forth, but the important thing on this is to differentiate it from fainting. This is not orthostatic hypotension, and it's not patients that are feeling like they're going to black out. These people are mostly unsteady. Vertigo is the true sensation of whirling or falling. Vertere is Latin, it means to turn, and that's why the sensation of vertigo. And those are the patients that most always have some form of inner ear or vestibular weakness or labyrinthine disease. I'm glad that Spider-Man made a comeback, because in the old days, a few years ago before the movie came out, nobody else, younger than me knew who Spider-Man was. But you will be disabled if you have vertigo, particularly if you drive, if you operate PTOs, power equipment, anything that there's a chance to be injured because of loss of balance. So that's one of our basic concepts. The anatomy of equilibrium control is pretty straightforward. The peripheral nervous system that we evaluate and then that we're trying to determine if it's out of kilter or not are the eye muscles to the labyrinth. And that's what gives us our vestibular ocular reflex. The inner ear goes directly to the muscles of the eye, and that's why we will be able to follow patients looking for nystagmus. It doesn't have anything to do with the vision. It purely has to do with the muscles that go to the extraocular muscles. The statokinetic system is the labyrinth. That's the two portions of the labyrinth. One of them is for linear motion, the saccule and the utricle, and the other is the ampulla, which is the sensation of turning. And so we end up living in 3 dimensions. You have to have all 3 functioning. And then the proprioceptive system is very commonly disturbed in people who have vascular insufficiency, diabetes. The soles of their feet don't work very well. Their fingers don't have good tactile speech. Those 3 systems are what we have to monitor, because the body will tolerate one of those systems not acting very well. The other 2 will take over. If you lose 2 of them, you're pretty much incapacitated and not able to function. We're trying to differentiate all this from systemic problems and central nervous system problems. Central nervous system systemic problems are going to be metabolic. We're not going to be able to surgically impact those, but those from the peripheral nervous system we can help. The statokinetic system will give you this abnormality, will give you the sensation of motion or falling. Again, that's the labyrinth, and it can extend all the way up to the vestibular nuclei and nerve. The systemic system, obviously, endocrine, orthostatic, cardiovascular, you don't get the sensation of falling. You have a sensation of unsteadiness. Hearing loss is really important because it helps us localize which side the problem is coming from if it's a peripheral disease. You might recall the 8th nerve is half audiologic and half vestibular, and there's some crossover fibers. Medications, particularly central nervous system sedating type of medications, will often cause a lot of side effects. And then, of course, the history of trauma is usually a little more straightforward to get. However, wife abuse or spouse abuse is oftentimes not specifically mentioned unless you ask about it. Getting cuffed on the side of the head is a good way to get a vestibular event. From a physical examination, and these are all things you can do in your office, nystagmus is by far the most important physical finding, not only because it lets you know that there's probably something seriously wrong with their balance system, but also it helps you to, is it coming from the inner ear, the central nervous system, or is it from the posterior semicircular canal, giving them rotary nystagmus, and we can actually treat that in the office. So horizontal nystagmus, and that's nystagmus going in this way, and we're looking at the fast and the slow movements of eyes. That's what this diagram is trying to show. Vertical nystagmus, there's nothing that causes vertical nystagmus other than a central nervous system abnormality. So that's, you know, if you see vertical nystagmus, get an MRI.
Could
And then
you-
rotary nystagmus is, you know, in the last 10 years become way more commonly diagnosed because that's what you see with benign paroxysmal positional vertigo. You put the patient in the dependent ear down position, and that will cause them to have rotary nystagmus towards the ground or towards that same ear. And that's very treatable with physical therapy maneuvers. In the old days, you know, this is a Netter drawing, of course, for the plus 20 diopter glasses or the lenses. And all that did was magnify the eyes so that you could see the movement and made it so that they couldn't have fixation suppression. You can overcome nystagmus by staring at a wall or staring at something in the distance, particularly if it's fine nystagmus. And we don't use barbiturates near like we used to, and so it's a little less common of a problem to diagnose. From a physical exam standpoint, cerumen impaction in foreign bodies can cause you to be off balance, particularly people that are pounding cerumen into their ear with a Q-tip, or hearing aid users that never clean their ears. They just keep forcing more wax, and it causes a disturbance of the inner ear. Chronic otitis media. I know a lot of you guys will see a lot of fluid. If they have severe negative pressure in the middle ear, they have fluid behind the ear. It can, if it's chronic in nature or gets secondarily infected, it can cause you to be off balance. Eardrum perforations, cholesteatomas can cause erosion of the semicircular canals. Those types of balance disturbances are usually pretty profound. They're usually vertiginous almost any time they have contact with suction or with pressure changes, and that doesn't go away with time. Usually that comes and it stays. From a functional screening test, I mean, you can get these even functional screening tests. They'll often even bring in from school screening tests or from job employment from Union Pacific or some industrial type place. And you're looking for pure tone testing. And you just want to be able to compare the left and the right. But particularly with acoustic neuromas and Meniere's syndrome or with labyrinthitis, you're going to have a hearing portion of the eighth nerve is going to be involved, and it really helps you localize which ear is causing the problem. A monitored fistula test is a test where we put on we're looking for leaking of fluid within the inner ear, and it's usually brought on by rapid atmospheric pressure changes from an airplane or scuba diving, or also from spouse abuse, from getting slapped on the side of the head. And the ENG, again an old Netter slide just because they were so classic, has changed a lot. You know, it used to be you had to irrigate with water and it was cold temperatures and all that kind of stuff, and that's really, it's a little bit on the messy side. It takes quite a long time. They've changed it now. They're called VNGs, for video nystagmography. So they watch the eyes with video cameras, and some of the newer systems have air that's warmed and cold, and so you don't have water coming all over. It's a little easier, cleaner for the patient. More importantly, if they have a hole in the eardrum, you can do the test. If you had a PE tube or if you had a hole in the eardrum, you can't do a classic ENG, and that can really, particularly in an otologic practice, eliminate a lot of people that you can actually evaluate. So as part of the ENG, it's a battery of 7 subtests. Only 2 of them are really looking for inner ear disease. The rest of it are all looking for problems with the central nervous system, and was basically designed for neurology examinations. The calorics, or the temperature changes from ear to ear, is what really gives us the most information, and it's the only test of all the functional tests we do for balance testing, other than MRIs, that tells you which side is involved, and that's the caloric side, the side that's not functioning very well. The Dix-Hallpike positioning is what is done to stimulate benign paroxysmal vertigo. That's where you lay the head over the table by 30 degrees and turn one ear towards the ground and then repeat it on the other side. And if they get rotary nystagmus, that's BPPV. From one point, if you do have a patient coming in complaining of a balance dysfunction, go ahead and get an ENG or order one. I mean, particularly if they complain about the sensation of movement. I feel like I'm falling. I mean, there's a good chance that that's going to be an abnormality on a VNG or an ENG. Benign paroxysmal positional vertigo is by far the most common cause of vertigo that I see, and I know for sure it's the most common vertigo that primary care physicians would see. It does have a female ratio of 3 to 1. 5th or 6th decade is by far the most common. The classic history is that they have vertigo when they roll over in bed, or they have vertigo when they lift up to shave their neck if it's a guy, or lift their head up to look into a cupboard if it's a woman. Mechanics have a lot of problems if they're laying on the ground. Farmers and stuff, they're laying underneath their machinery, and then they look back up and they start, I just got a sudden onset of balance disturbance. It can make you nauseated. it passes. It goes away if they get out of that stimulating position, and so that's the huge benefit of it. They make a difference between whether it's cupulolithiasis or canal lithiasis. It doesn't really make a lot of difference from a practical standpoint. Canal lithiasis explains why when you put your head into this dependent position, there's a lag period of time, and it's because the stones that are falling off the ampulla are actually pulling the fluid with them, and it's the fluid movement, not the actual stimulation of the stone coming off the cupula that causes the balance dysfunction. And it just explains why when you put the head in that position, there's a delay before it starts. The classic BPPV has a latency, and then it fatigues. It goes away. If you have someone who has a balance problem and it doesn't go away, it doesn't adapt, it's probably a central nervous system problem. And again, get an MRI. The reason VNGs or ENGs work is that the retina and the cornea are positive and negative electrically in relationship to one another. Keep in mind, an ENG does not diagnose a specific pathology. It really only tells us, as part of the test battery, which ear is causing the problem, which is incredibly important. But there's no one balance test that will tell you what the problem is. You have to add them together. ABR, audiometric brainstem response, is part of the screening test for almost every hospital now where they have retrocochlear waveforms. It's 80% accurate. It's very inexpensive, particularly when you compare it to the price of an MRI. It does require specialized equipment, but anymore with the neonates having them, they're way more common in hospitals. The specialized testing, I only show you pictures of them just so you know that they exist. You know, I do a lot of litigation work, people who have had gentamicin, neurotoxicity, aminoglycosides of any kind. The only way you can really test for that is in a darkened space. This is a room where this chair actually spins. When they say rotary chair, it's exactly what they mean. And this door closes, and then you watch the patient's eyes on an infrared camera to measure their amount of dysfunction. It's the only really good way to test children as well. Fortunately, the children don't really get vertigo. You know, it's very unusual for me to see children that have balance disturbance, and it's usually pretty straightforward when they do. Posturography has become incredibly common in the last 20 years. Basically, it's used both for compensation for patients, that meaning a form of physical therapy, and it lets you know if the inner ear the function of a diseased inner ear has been compensated for by the central nervous system. You can have one inner ear completely gone and the other side can completely take over, given a 6-week to 6 months period of time, particularly if you stimulate it in a proper fashion. So just because you've got a neurologic loss doesn't mean that you can't get compensated. I mean, we have guys that have had nerve sections that go back and play golf and do any other what I consider a difficult hand-eye coordination sport. Monitored fistula tests are very simple. They're done in almost every audiologist's office. They have a pressure that goes into the ear. They monitor eye movements. And again, you're looking for a fistula, a leaking of fluid from the round window or the oval window, and it's very easy to fix. From a radiographic standpoint, CT scans and MRIs have specifically different uses. The CT scan, really from our standpoint, because it identifies bone trauma, really is only helpful for us in traumatic cases. Clearly something that shows you a longitude or a fracture across the temporal bone like this, back to here. This person's not going to have hearing. He's going to have a balance disturbance because the 8th nerve has been fractured, but it's not going to really help us very much with a tumor. This bottom one is an MRI, which shows you the outline of a relatively small acoustic neuroma. And both of these would present with dizziness, and both of them would present primarily with hearing loss. Of course, the thing that separates this off is the history. Some MRIs are very helpful, particularly when you're looking for multiple sclerosis. MS is responsible for, about 7 to 8% of patients that have MS will present with vertigo as their initial symptom. That's not a small number. And so to get an MRI on people that you suspect of having MS is very reasonable. And it's very characteristic when you see it. The true vertigo differential, as an overview, the things that we primarily see, and this is the order in which we see them in frequency in our office. Benign paroxysmal vertigo is the most common. Meniere's syndrome second. Neuronitis and labyrinthitis we separate out. They can both be caused by viruses or decrease in blood flow. It's just that when you have a vestibular neuronitis, you do not have a hearing loss. When you have a true labyrinthitis, you have both a hearing loss as well as a balance dysfunction. Perilimb fistulas are almost always due to some form of trauma, whether it's a rapid descent in an airplane or a rapid descent from scuba diving or from somebody slapping somebody on the side of the head. Acoustic neuromas almost always present with a hearing loss, and the sensation of balance disturbance is more of an unsteadiness rather than falling. MS is usually not diagnosed by us, but we still diagnose 2 or 3 cases of MS a year primarily and send them on to a neurologist. Vascular loop syndromes are becoming significantly more recognized as a cause of hearing loss and balance disturbance. You know, facial nerve hemispasm, where the facial nerve is irritated, and trigeminal neuralgia, where you have facial pain from the 5th nerve being irritated, have pretty much for years been realized that that's from vascular irritation or compression of the nerve by an artery. And you operate on those by separating the artery from the nerve, putting Teflon sponge around it, and the success rate is incredibly high. There's a lot of work being done on vascular loop syndromes for hearing loss and balance disturbance as well. Getting the irritation of the constant artery compression on the nerve to be relieved and the patients do better. I put syphilis down here. We only diagnose 1 or 2 cases of syphilis at the most in a year, and that's usually by accident. But the only way we end up getting it is FTA-ABS tests. VDRLs most of the time aren't very effective, particularly if the patient's been treated in the past. They get an endarteritis. It's an obliterative endarteritis from a pathologic standpoint, and their symptomatology is by no means the same. I mean, it varies all over the place. These are the different positions you put patients in for benign paroxysmal vertigo. And what you're trying to do is to stimulate the posterior canal to see if there are stones on it. And I know that there's a large number of you guys do this in your office because I'm not doing near as many of them as I used to, which is good. We don't need to. The Epley maneuvers were named after a neurotologist from Portland, Oregon, who about 10 years ago described all this, where you place the patient's head 30 degrees over the end of the table with whatever affected side you think is causing the problem towards the ground, and you have them keep their eyes open. The catch on this is to have the patient looking at you so you can see the rotary nystagmus, and this isn't something that's subtle. I mean, they feel like they're going to fall, they'll grab onto the exam table, and you can just watch their eyes rotate. And then it will subside. You'll have an initial latency where you put them into position, nothing happens. And then the rotation starts, and it becomes more of a crescendo, and then all of a sudden it stops, and they feel fine. That's when you start to do the maneuver, and that's what the Epley maneuver will do. And it takes us about 5 minutes to 10 minutes on a patient. After you explain to them, it's got about an 85 to a 90% success rate. Keeping in mind on some of these patients, you'll have to do it up to 3 times to get all of the little particulate matter out of the posterior semicircular canal. The Dix-Hallpike maneuvers are what you do to put the patient so that the ear is down and dependent to see if they have rotary nystagmus. That's all that is. That's where that stops. Epley maneuvers then will go and take that patient from that position, drop their head down, rotate them over to the opposite side, sit the patient back up, bring their chin back up, and then normally you put a soft cervical collar on. One is a continuation of the other. The other maneuver that can be done is called the Samant liberatory maneuver. This was the original maneuver that was described on how to get rid of stones within the inner ear, and was actually before World War I. But it requires the patient to be able to be somewhat agile and flexible. Most of the patients I do this on are significantly heavier and older and are not mobile enough to really do this without, and so I don't really do it very often anymore. But basically you're taking the patient from a sitting position and laying them with their head up. Then you will, in one quick movement, have to move them all the way to where their head is now doing a face plant. And then you turn their head back up. I don't see any reason, and in fact I haven't probably done this for 3 to 4 years, but it's just in case, they talked about it in case someone had a lot of very severe compression or a lot of problems with neck problems that they couldn't move the neck. But you still have to move the neck, even on a Simot maneuver, to turn the head back up. Meniere's syndrome is essentially endolymphatic hydrops. It has definitive criteria, which is pretty important, particularly when you're doing medical legal work. Meniere's is forever. It's like diabetes. You don't cure Meniere's. You can treat it. You can try and make them feel better. So be careful about writing down that they have Meniere's syndrome. Vertigo of unknown etiology is just as good. A Meniere's attack has whirling vertigo. They have progressive sensorineural hearing loss, usually in the low frequencies. They have tinnitus or ringing in the ear and oral fullness. And it is sporadic and episodic. Their physical examination is completely normal. It's treated by symptomatic and supportive treatment. And basically, the problem is fluid gets in the endolymphatic scala media, and it ruptures Reisner's membrane. As the pressure within this, the scala media gets elevated, it will rupture this one cell thick membrane, and the high potassium concentration here now mixes with the high sodium concentration, and it causes a balance disturbance. The reason the attack lasts less than 24 hours is that this is only one cell layer thick, and the ATPA is pumped to get everything back, and usually within 24 hours or less you can be functioning fine. The way we treat Meniere's syndrome from a lifestyle standpoint is with CATS therapy, and put the CAT in here just to remind you that CAT stands for caffeine, alcohol, tobacco, and either salt or stress. And if you can get patients to avoid that with lifestyle management, most of these patients don't need much more than salt restriction, maybe some diazide and an occasional benzodiazepine or antihistamine. We do have all of our patients keep a diary of when they're having hearing loss, when they're having balance problems, because they usually underestimate how many times they've had bouts over a 3 to 4 month period of time. The treatment we use medically, benzodiazepines, usually Valium or Ativan. I have a lot of patients that use the real Ativan will absorb underneath your tongue. It doesn't have to be taken and swallowed. If you're nauseated, a lot of times you're not too interested in drinking a lot of water and taking pills because you'll vomit it back up. A milligram of Ativan will absorb sublingually, and you'll get into your system in about 5 to 10 minutes. Meclizine is an otolith suppressant. It's not a vestibular suppressant. It's an antihistamine. It's excellent if you're having unsteadiness. That's why it's so good on boats and cruises, that sort of stuff. Scopolamine, I avoid. It works if you're on a cruise. A lot of those patients will get maldebarkment syndrome when they take it off. It means that they'll feel worse when they take it off, so they continually keep using scopolamine. But if it works for them, it works for them. Again, the definitive criteria for Meniere's is important, because you don't want to label someone with a disease. It makes them hard for them to get insurance if they ever change insurance companies. They call it a pre-existing condition. The surgical options are really pretty straightforward, and we only operate on about 20% of our Meniere's patients. And by far the most conservative operation is an endolymphatic shunt. It's done as an outpatient. It has about a 70% success rate. It takes us an hour to do, and most of them do very well. A vestibular nerve section, the patient has to be hospitalized. It's got a 95% success rate, but you're in the intensive care overnight and you're in the hospital for a few days, and we actually separate the hearing nerve from the balance nerve, so we preserve their hearing and we get rid of the balance problems. But it will take them probably 6 weeks to get back to where they're really functioning at the level that they think that they need to function. Labyrinthectomies are very easy to do because you're not saving any hearing. And the success rate on a labyrinthectomy, again, is about 95%. The reason these operations aren't 100% effective is some of the vestibular fibers run on the facial nerve. You might recall the hearing nerve, the balance nerve, and the facial nerve all come together, and obviously we can't take any of the fibers off the facial nerve. Chemical ablation has become something that we're doing a whole lot more the last 5 years. We use gentamicin. We infuse it into the inner ear through a special microwick, and it will absorb through the round window. We do this in elderly people who can't tolerate surgeries very well, particularly cardiopulmonary patients. The trick is to give them a low enough dose for a long enough period of time so that it does not kill the hearing while it's destroying the vestibular system. Gentamicin is vestibular toxic primarily, and only after a long period of time or a longer period of time will it kill the hearing nerves. But even at that, it's still about 25% of our patients end up getting both balance destruction and hearing loss. So if they've got good hearing and they're not elderly or they can tolerate a surgical procedure, they're probably better off not having chemical ablation. The differential for trauma, it's very straightforward from its history. So much of what we see, in order to get a temporal bone fracture like the picture I showed you before, it almost needs to be a motor vehicle accident. That's a very difficult bone to fracture. 3D scans are nice. They don't really help us a great deal. We do get hearing testing and balance testing on these patients mostly as a prediction of whether they're going to get their function back or when we can start to do rehabilitation. Acoustic neuromas do not normally present with balance problems. 95% of my patients have hearing loss. A one-sided, sudden sensorineural hearing loss is, in an ear, nose, and throat office, an acoustic tumor until proved otherwise. It can masquerade as Meniere's, perilymph fistulas, or even a vascular insufficiency, but clearly you don't want to miss it if it's there. ABRs will help diagnose most of them. And the treatment at this point is either surgery. Stereotactic surgeries become available in the last 10 years, particularly around here. Again, elderly people who are not good surgical candidates. And there's a large section of smaller tumors that we're recommending observation. Just get repeat MRIs on a yearly basis for a while to see if there's any growth, unless the patient's too symptomatic. The perilymph that we can control is around the oval window. This is where the stapes joins the cochlea, and this is the round window. Those two areas are by far the most common where you can have fluid leaking out of the inner ear. If you have perilymph leaking out of the inner ear, the nerve tissue will die. And not whole unlike oil coming out of your engine, the difference is the body's trying to heal this. No one's trying to fix the oil leak in your car. And so most of the times these things are sporadic. And if you have a rapid pressure change, you get dizzy, you get a hearing loss, the body tries to heal it, it seals off that leak, and the hearing will restore itself most of the time almost to the level that it was before, and the balance dysfunction goes away. The problem is if you keep flying over and over and over and have this, or you keep scuba diving, it will keep coming back. Eventually it needs to be fixed, it's very easy. You just put tissue over it to increase the thickness. This has really become more common as people are getting into domestic violence histories just a little bit more, and I would urge you to look into that. And the reason that works is purely hydraulics function. This is the size of the eardrum, this is the size of the round window, and it's 17 times larger. And then if you take your hand palm, it's another 10 times bigger than the eardrum, and so it's just a hydraulic effect. So not much of a hit out here can cause a lot of problems to the inner ear.
Sir, I think I read an article about this also being caused by people who are really straining hard with severe constipation.
Yeah, guys that are severely constipated, weightlifters, particularly people that are doing significant weightlifting. But yeah, anything that increases intrathoracic pressure from below can also cause you to get a perilymph fluid leak. It's very fixable, and it's pretty easy to diagnose. It's a very non-invasive test to diagnose. This is what an MRI of MS looks like. These are basically the little diffuse oval-shaped lesions that will occur, and they'll occur at all kinds of different levels across the MRI cut. And again, it's just one of those things, if you don't suspect it, you probably aren't going to diagnose it because you don't think of MS having vertigo. As a summary, we do want you to understand the difference between vertigo and dizziness. Vertigo is the true sensation of spinning or falling or moving. Dizziness is unsteadiness. The major reason we're trying to find the difference is vertigo is almost always caused by inner ear disease from the labyrinth, whereas dizziness can be from the central nervous system, the proprioceptive system, as well as the inner ear. The functional screening exams are really pretty straightforward. Audiometric studies, ENGs, and monitored fistula tests are very inexpensive. I think a VNG is less than $200. I mean, so when you start comparing that to MRIs and CT scans, it's relatively inexpensive to work these up as screening functional exams. Radiography, the CT scan is good for bony detail. MRIs are what you really need for soft tissue detail, and it offers you so many more things that if you're only going to get one X-ray, probably get the MRI with gadolinium or some form of Magnavist enhancement. The medical and management of acute vertigo, the symptomatic treatment, we normally have to hydrate people. don't hesitate to give them true vestibular suppressants. And a true vestibular suppressant is either benzodiazepine, Valium, Ativan is excellent if they're not going to be kept in the hospital and you want them to be able to get high concentrations. BPPV has a classic history. They roll over in bed, they look up their head, they get vertigo. The Dix-Hallpike is a diagnostic rotary nystagmus. That's how you diagnose it, is with Dix-Hallpike maneuvers. The particle repositioning is done by the Epley maneuvers or the Samant maneuvers. Epley maneuvers are 85 to 90% successful. Forewarn your patient, you may need to repeat this 2 or 3 times. If you tell them ahead of time, we may have to repeat it 2 or 3 times, they'll accept it. If you do it one time and they come back again, they can't figure out why you have to do it again. They think something went wrong. If it does fail 3 times, go ahead and get a V&G. The specialized functional testing, there's really not very much reason for you guys to spend much time on rotary chair or posturography, other than that posturography really is very helpful to us in rehabilitating these patients. And we can follow them objectively on how their physical therapy is going, particularly in elderly people who have more than just inner ear disease going on. Posturography has been incredibly helpful to us. And basically, the only people that we do surgery on are people who are uncompensated or who are medical failures, which ends up being a pretty small number. Many people can be cured. You can't cure these people, but almost all these people can be helped to a certain degree. Because if you start getting elderly people falling, you're going to get fractures. And if you get hip fractures and ankle fractures, you're going to have a whole lot more morbidity and mortality. This was a picture of a little penguin walking by and getting tripped. And so just when you think that everything's going well, something else can happen. You can have multi-system disease. Just because you have inner ear disease and you fix it doesn't mean they also can't get atrial fibrillation or some form of decreased blood flow and have more than one thing going on.